Yeah, Lisa has told me a bit about my background. So have a look here at the map of the Netherlands. It's a bit vague. But Enschede, the University of Twente campus, is on this side of the country, just about due east from Amsterdam, where you hit the German border. This is where we are. It's a University of Technology, one of the three in the country. And so we're in the part of the country, so roughly below this line is the part of the country that's above the sea level. So with the global warming, maybe soon we'll have a nice campus on the beach. So we'll see. Yeah, so today I'm going to talk about healthcare operations management, and Lisa will ask me to enthuse you guys, industrial engineers, to start working in the field of healthcare operations management. And if you look at this field, it's still very much in its infancy. Some 10 years ago, Michael Carter, a professor in operations research in healthcare in Toronto, said that less than 5% of the operations research management science community is actually focusing on healthcare. And if you look at the size of the sector, that's a really low number. Now, we've seen an increased interest in the last few years, but you could still say, in comparison with industry and transport sector, for example, and defense, healthcare operations management is still in its infancy. But nevertheless, we have huge problems. There's quality problems. Netherlands has the highest quality of care in Europe, but in Europe, 95,000 patients per year die of medical errors. That's roughly 300 planes crashing every year. In the US, it's roughly a Boeing 747 every day, with people dying of medical errors. Also, another big development in the Netherlands is a demographic development. You can see it here. It's the doubling of what we call the gray pressure. So the share of the population above 65 divided by the people actually working in healthcare is doubling. So that means that if we want to maintain this quality of care, we really have to rethink the way we organize our processes. So the population is aging, and unfortunately those extra years are added at the end. And that's not our most healthy years. And you can see that in this graph. This is the spending related to the age groups of the people, and you see the older people get, the more money is spent in the healthcare system, well, with the exception, of course, for infants. Older people require more care and require more complex care. Comorbidity, meaning occurs more often for elderly people. This means that people have multiple complaints at the same time. So it's not possible to offer to upscale large quantities of standardized care, because people typically have multiple complaints at the same time. They have a heart condition, they're diabetic, and they have the bad hip all at the same time. So that requires adjusted care. Also, efficiency is a problem, and in the Netherlands, we've been doubling our expenditures every 10 years for the past 40 years. And this curve is still increasing. And we're not the only country doing that. You see that across the board around the world. And the spending on healthcare in the US is nearing 20% of the GDP. So can you imagine, 20% of the GDP. And in the Netherlands, we're around 13% at the moment, and we're some of the highest spenders after the US in the world. So we cannot keep on spending so much money on healthcare, and we have to really rethink the way healthcare is organized. Now, I'm telling you this, but if you look at the literature, it's funny enough, if you go back to the 70s and all the way up to now, all these articles on healthcare operations management start with, healthcare is rapidly changing and now is the time that we should get into, So people have been saying this throughout scientific history, right? Well, this is the daily challenge of hospitals. So waiting time in the ED, in outpatient clinic for diagnostics, access time for surgery, waiting list, running and standing still, overtime, cancellation of patients, improper use of facilities, conflicting autonomies, waste of materials, waste of facilities, lack of space, all at the same time is happening in every hospital in the Netherlands, but surely that's happening here in South Africa too. And there's a lot of low-hanging fruit. And this is the first project I did in healthcare. I encountered in 2003. That was 2 years after finishing my PhD. I was still focusing on industry, planning and scheduling. And then suddenly, this operating room manager of Erasmus Medical Center, a big hospital in Rotterdam, came to me. He said, with your knowledge of planning and scheduling, you can do wonderful things in healthcare. And nobody's doing it at the moment. So please come and help us. So I went over there. And I found out that they actually have 10 years of historical information of surgeries. There was an anesthesiologist who said 10 years before that, we have to clock everything that happens in the operating room. And actually nobody had ever looked at that data before I came there. So I requested, so is there any logistical data, timestamps that we can have a look at? So I got this database, and the first thing I looked at is difference between the planned duration of the surgery and the actual duration, because they were complaining about having to cancel many patients at the end of the day. So patients have to be sober until the surgery, cannot eat or drink. And then, you know, the program learns late, and then they say, sorry, we can't make it, so we'll try tomorrow at the end of the day, right? And staff complaining about overtime and running and standing still. But the operating room manager gave me a tour of the department, and left and right operating rooms were empty, and the coffee room was nicely filled. It was really cozy. So he said, we're not doing things in a proper way. So help us with that. So this is what I looked at, and in this graph you can see the difference between the planned and the actual duration. And what you see here is that roughly on average a 40-minute difference. So surgeries on average, 28,000 surgeries per year, on average took 40 minutes longer than expected. You can imagine what kind of impact you would have. Any ideas why this is? Why 40 minutes? You know. I'm sorry?
Doctor's arrogance.
Doctor's arrogance, yeah, that's what my students often say when I ask this in class. No, it's actually... I'm sorry?
Coffee break between operations.
No, but you're close. It's the doctors estimating the time of the surgery, and they actually estimate the time that they are with the patient. But there's a lot of time surrounding that when the patient is being brought in, is being revived after the procedure, the operating room needs to be cleaned, and on average this is approximately 40 minutes. So the first thing I did is that use your historical duration to plan patients, and that increased the utilization by 15%, reduced the cancellations to very low numbers, and we were all over the news, right? We were on TV, we were on the radio and doing this fantastic thing, and the only thing I said was use the information you have, right? So I never wrote any paper about this, but it has huge impact on this hospital. And an important consequence for me was many hospitals approached me now, can you do this for us too? Because this sounds fantastic. We want to have these kind of efficiency improvements as well. So this is how I got started. And these are the kind of problems that you encounter in hospitals. The ICT systems are poor, and they're currently being improved, but nevertheless they're still quite poor. So they store data, but for financial and medical reasons, not for logistical reasons. The departments are organized as single cost centers, so they each have a manager trying to optimize that department, right? So they're like silos, and the patient actually doesn't care about these departments. The patient typically needs a couple of these departments and suffers as a consequence, because the patient is sent from one department to the other and has to wait again and again, has to do his story again and again. Hospital managers also have a subjective idea of performance. There are no KPIs measuring the performance. So yeah, if you don't measure the performance, then you cannot improve it, right? If you don't measure your ideals, then the measurable becomes the ideal, right? And it's all about money in the end. So the hospitals are mostly run based on money, on profit and costs. Management is poorly trained, typically have a medicine background or a nursing background, and this is where you're taught for 12 years to learn everything about this bit of the human body. And this is how they also manage their processes. They look at a specific department, and particularly the operating room department is regarded as the most important department, so that has to be optimized and the rest has to follow. And consequently, it's like a supply chain. You get bullwhip effects, and patients are waiting, and staff is running and standing still. Conflicting autonomies, so doctors, they get involved with inventory, so before they go to surgery, they will look in the warehouse whether there are enough suture materials and latex gloves, and if they find that the levels are too low, they will make rush orders because they can, right? And there's a material guys taking care of that, so you get a lot of inefficiency as a consequence. There are perverse financial incentives. So we used to have a budget system, so a hospital would get a fixed amount of money, and they would make sure to spend it in a year, because if you're more efficient, then you would get less money in next year. Right, so that doesn't really lead to efficiency improvement. And very dogmatic decision making. I will come back to that later. So 15 years ago, the waiting list in the Netherlands was a status symbol for doctors. You don't have a waiting list, you must be a terrible doctor. And this was found perfectly normal. And my grandmother, actually in the 90s, she needed a hip replacement, and she had to wait for a year and a half for the surgery, and got morphine to deal with the pain. And after the procedure, which is a fairly standard procedure, she had to kick the morphine, and then her heart suffered as a consequence, and she died. So she died as an immediate consequence of the waiting list, actually for a fairly standard elective procedure. So, but things are changing because patients are getting informed better, and media was paying a lot of attention to cases like that of my grandmother. And patients start to be more demanding towards doctors. They start shopping to find the best doctor for a certain procedure. And the hospitals in the Netherlands, they were inclined to perform all care for all the patients in the catchment area. So you would have doctors that do 3 breast surgeries per year. So the doctor is not very qualified to do that, and you get a poor quality as a consequence. So our government is introducing market mechanisms in the market. So hospitals now have to choose what they focus on, so they can have a big volume and increase the quality of care. But as a consequence, they also have to rethink the way they organize the process. It has a big impact on how many resources you should use, how you should plan, and so forth. So market competition is being introduced, ICT systems are being introduced, electronic health records, health information systems, data mining and data visualization tools. Standardization is a big thing, so just standardizing care pathways. It's as if the Philips people would sit together one day and, we have to discuss with each other how we make a TV, and each of us, we all make it that way. I mean, in industry, that's where you start, right, to make a design. But this is actually now being done because doctors treat patients in different ways, similar patients in different ways. Big focus on reducing length of stay, the number of beds, and reducing waiting lists. Operation management experts are being introduced from other industries, and logistical paradigms are also being introduced into healthcare. Lean, Six Sigma, TOC, BPR, TQM, and all these paradigms. So this initial project, after a few years, having done many projects, led to the founding of a research center, which Liesel just introduced to you. This is our website, so have a look there. All our publications are there if you want to know more technical details. This is the mission that we have. So we want to help care providers to reach their productivity and quality of care and quality of labor goals, and we want to actually make an impact. And how do we do this? Of course, we have a scientific multidisciplinary approach because healthcare inherently is very multidisciplinary. We use quantitative techniques and ICT because with mathematical models and simulation models, we can prospectively assess interventions in the planning and control of processes before we actually experiment with that in practice, which can be really dangerous. And we do that together with the care providers. We have in our center right now 10 PhD students, and we've positioned each PhD student in a hospital. So they are there for 3 days a week, and Thursday, Friday they're at the university to collaborate and to get their supervision. So in these hospitals, they are the to-go guy or girl for logistical problems, right? So our research agenda is entirely driven by questions from practice, and there's a wealth of wonderful operations research, operation management questions that we get from that, far more than we can take on. So we sift out the questions that we find in multiple hospitals so that if we solve that question, we can actually help multiple hospitals at the same time. Also, our PhD students have to spend 1 day a week on impact-related work, so simply implementing the outcomes of their research. So we have a lot of PhD students, also staff involved, of course. We work with hospitals across the country, all kinds of hospitals. Also, we involve bachelor and master students who have to do graduation projects of 3 and 6 months, respectively, in a hospital, and typically under supervision of our PhD student. Now we have bachelor and master programs, industrial engineering and management with a specialization track in healthcare technology management and logistics. We teach healthcare administrators and clinicians. So I have a 1-day course for clinicians, a crash course on operations management, and we have an 8-day course for administrators that want to go more in depth. And also we have a 2-year postdoctoral engineering program on healthcare logistics. And then also we have a spin-off company, which is a collaboration between the university and Ortec, world leader in decision support systems. And it's staffed by former students and PhD students. It's run by them. And what they do is they bring the results of the research to practice. They build the decision support tools, the dashboards. They do the project management. They do the education. And part of the turnover of the spin-off flows back into research and feeds then, our funds our research. So we have a nice ecosystem, if you like, with practice. So we have questions coming from practice, coming to our PhD students, or coming directly to me. We do research. We try to involve the practitioners as much as possible and speak their language. The research results typically in a paper, and we we realize that the easiest solution that works in practice is the best solution, because that's the solution that's probably going to be understood by people and then adopted. But the mathematically optimal or near optimal solution is probably so complex that people won't understand it, and you will not be successful implementing it. Now, that easiest solution that works best is not a solution that you can typically publish in the operations research literature. People won't be interested. So we do both. We try to find that optimal solution or near optimal solution, and we try to come up with a really easy to use approach that has a good performance. And having that near optimal solution, you can relate that performance to that optimal performance. So you actually know, do I need to invest more in training people to get more, a better solution? Or are we already nearly there, and well, why put in the extra effort to get that optimal solution? So the research results in a prototype, and then our spin-off then implements the outcomes. That often results in new research questions and solutions, of course, and students are involved in the entire process in doing graduation projects and education, of course, education of managers and clinicians. The students, they actually make the biggest impact. So far, I've supervised over 200 master graduation projects in healthcare, and some 60% of the students actually stay to work in healthcare. And these are students that typically didn't plan to go and work in healthcare when they started studying industrial engineering and management, but they were grasped by the topic and enthused by the topic, and they find that they can do really wonderful work in healthcare. And they're like an oil stain now going around the country, and they're feeding us, of course, with lots of research questions, and we never have a shortage of research questions and internship positions. Teaching healthcare management is very much fun. It's also rewarding, also financially rewarding, so that feeds our research center. But these people get really worked up about operations management, and they're the new champions that will approaches, you know, often with new challenges for research. We try to speak their language, so we don't speak of problem analysis, we speak of anamnesis, which is a medical term, right? We don't speak of solutions, we speak of interventions. A surgery for a doctor is an intervention in the patient, so it's managerial interventions is a term that, or organizational intervention, that resonates much better. We don't speak of models or quantitative experiments, we speak of controlled perspective assessment, right? Or not optimization, but improvement. And when we speak of performance, they associate us with working even harder, but we time and again explain it's about working more clever. So it's about improving quality of labor, it's about improving quality of care and improving productivity, all at the same time. Of course, in our world, we typically use a design approach, of course, with empirical elements, but for clinicians, this is very odd, right? Clinicians were taught to do everything they do with a patient right in the first attempt, whereas engineers, they experiment. You build a prototype bridge, it falls apart, and you say, oh, that's interesting, what happened here? And you learn from that, right? But this is very unusual for a clinician, and consequently, when they do management, they're very much risk avoiding. So we have to deal with that, we have to explain that. So how do we do it? So hospital boards often approach me with questions like, we want to have integral control over the patient process to integrally optimize them. And you could say there are two approaches. There's a top-down and there's a bottom-up approach. So the bottom-up approach is that's the world of the logistical paradigms. It's the world of creating a culture of continuous quality improvement, of harvesting low-hanging fruit, of getting everybody in the organization involved in thinking about what is the value that we add, what is the waste, try to eliminate the waste, try to eliminate variation, with all kinds of paradigms that you see now in healthcare. And hospitals, they choose for one of these paradigms rather based on an enthusiastic consultant than on proven effectiveness for their given situation. So one hospital is doing TOC and the other is doing Lean and the other is doing Six Sigma, and then there's one doing Lean Six Sigma. And well, I started thinking about that, and if you look at all of them combined, what you see, what they have in common is they strive for continuous maximization of value or elimination of waste, reduction of variations and variability, and reduction of complexity, right? Reduction of complexity means planning is complex, so if you organize things as simple as possible, do today's work today, don't plan appointments, organize on a walk-in basis, it's not complex. Just in time, in a sense, is also a reduction of complexity. Six Sigma, of course, very much focuses on reduction of variability and variations in quality, disturbances, and errors. And Lean very much focuses on maximization of value. But if you look at the vision or the mission of a hospital, the mission of a hospital is not to reduce variability. It's not to reduce complexity of their organization functions. Their mission is, of course, to deliver care for the patients in the catchment area or in the country. So it's the first one, it's the maximization of the value. And the other two are more internally oriented. So they have to do with how you plan and control the processes. And there's actually a trade-off between these two. Because if you want to reduce variability, typically you have to do forecasting, you have to do numerical analysis, clever planning. You come back next week Tuesday, then I have time for you, right? So that reduces the variability in the workload for the doctor. This is why we wait for our appointment. But introducing planning and forecasting and numerical, that introduces complexity. If you want to reduce complexity, well, then you don't plan at all. Like total access, basically saying don't plan at all, organize everything on a walk-in basis, do today's work today. But of course, as a result, you get a lot of variability. So the question is, for every hospital that thinks about planning and control, is how do you balance this trade-off? So how do you balance the reduction of variability and variations and the reduction of complexity in such a way that we actually achieve the targets that we have regarding the adding of value in the healthcare market. And this is actually what the top-down approach is about. Top-down is about integral planning and control. And integral planning and control means that it encompasses the entire care pathway, not just the operating room, not just the outpatient clinic, but all the stations that the patient visits during the care pathway. It also encompasses all managerial areas and all management or hierarchical levels of control. And to illustrate this, we use this hierarchical planning framework. Now you recognize probably the strategic and tactical and operational levels that were introduced by Anthony in 65 already, where we distinguish between offline and online. Offline is the short-term in advance planning, and online is the here and now, so the monitoring and control of the process when it happens. So these are the classical hierarchical levels, and vertically you see the managerial areas. So medical planning, in industry you would call this technological planning, so this is engineering, macro and micro process planning, but in hospitals, of course, this is clinical planning. It's the doctor that decides what care pathway you end up in, or whether you'll be anesthetized locally or entirely, or how urgent you are as an emergency patient. That's a clinical decision. That's not an industrial engineer decision. Resource capacity planning is about the planning of the renewable resources, so staff, equipment, rooms, and so forth. And materials planning, then the non-renewable resources, such as materials, blood, bandages, these things that you don't use again. And financial planning, I think, speaks for itself. Strategic planning is the level of planning where you look really far ahead. Demand is unknown, so you forecast the future. You look ahead for a couple of years, typically. But supply is also very flexible, so you can redimension resources, change layouts, train staff, hire and fire. So this is the level of strategic planning. At the operational level, at the short-term in advance planning, demand is actually known, except for, of course, the emergencies that you will know them when they're there. But the elective demands, so the plannable patients, they're known, and capacity is given. So there's typically appointment scheduling or nurse scheduling or surgery scheduling, which is done on Friday for the patients in the, next week. There's virtually no capacity flexibility. You cannot adjust capacity levels in this short term, right? So demand is given, supply is given, and then offline planning is then matching these two. And this is where we do, of course, wonderful scheduling, and you can do great operations research stuff there. At the operational online level, that's the monitoring and control of the process when it happens. And this is, where you don't want to be fixing things, right? This is really the last stage. If all the operating rooms are full and then there's a C-section coming in, has to happen right away, then they even have to break protocol and operate the patient maybe even in the corridor. That happens, you don't want that. In between is a tactical level of control, and it's very much an overlooked level of control. So at the tactical level, you look a bit further in the future than at the offline operational level, in the sense that you get more flexibility in your supply. So for a couple of weeks from now, you can have some temporary extra staff, or tell your people that 2 weeks from now we're going to work a bit more. Like in the Netherlands, when it starts to freeze, people break hips, orthopedics is busy. So you can predict it based on the prediction of the weather. You don't have that here, I understand, but that's a thing in the Netherlands. So you can arrange it in advance. And if you stick to the same amount of capacity every week, well then that week you will be terribly busy and patients will suffer as a consequence, and also your staff will suffer. So in the intermediate term, demand is partly known and partly you need to forecast it, but capacity is also flexible. So what you typically see is that managers, they're mostly focused on this level. So they're fixing problems when they occur, they're firefighting, and they feel very important doing that. Because at the end of the day, you fought 5 fires and you did a great job. And next day you have another 5 fires and you had another good day. But if the fires increase, they will immediately scream for more capacity. Because more capacity is the universal solution for all the logistical problems, right? And then immediately becomes strategic. So with the exception of endoscopy, I haven't encountered one single department in healthcare that didn't have sufficient capacity. Right? The managers are very risk averse, and if they have one experience when they were too busy, then they will scream for more capacity, and typically they will get it. Because doctor can make a very strong plea for getting more capacity and additional resources. So the tactical level is actually not even dynamically done. So the tactical level is, for example, the block schedule of the operating rooms. In hospitals in the Netherlands, compare the block schedule of this week with that of 10 years ago, plus or minus 1, it's exactly the same. And they repeat it every week and every week and every week, regardless of demand and whatnot. So demand varies, but also supply varies. Doctors go to conferences. And in hospitals, they urgently go to conferences, right? They say, oh, next week I have a conference in Orlando, so here's my surgery time back. And in that short term, you cannot call in other patients, so that capacity is underutilized. So hospitals need to redesign the planning and control, and there's not a universal solution, just like in business. Every hospital has a different idea of what is the performance they need to deliver and what kind of position they want to have in the market, and that determines then how they should design the planning and control. And actually, that's the same departure point as for example, lean. It starts also with what is the value that we're adding and want to add. And this is the same for when you design top-down, the planning and control. So it's the top-down approach and the bottom-up approach are very complementary. So I focus mostly on the top-down approach, because this is where we can use nice mathematical models and computer simulations to redesign the planning and control. But there's a lot of low-hanging fruit that needs to be harvested, and people won't be enthused about a new way of planning and control if even the simple things aren't done in the right way. So you need to do this bottom-up. And it will enthuse people to think about value adding, about optimization, and this will also feed the top-down approach with a lot of information, a lot of data that we can use for optimizing planning. So when we started doing the research since 2003, in the first years, we mostly focused on single departments, operating rooms, outpatient clinics, radiology. So just looking at that department, and we could do really nice stuff there. Let me give you some examples. So this is an elective surgery schedule. So these are blocks of surgery time. These are surgeries we plan in. This is slack time. And so we looked at things like, so how do you optimize the assignment of the surgeries? How to deal with movable equipment. So you may have 10 operating rooms, but only 3 C-rays that you move about. So surgeries are waiting for that. How many teams do you need during the night? How to benchmark operating theater departments. How to optimize the surgical instrument trays, how to calculate that buffer time at the end of the day, and many, many, many more. What you see typically is that hospitals buffer 2 hours at the end of the day, regardless of the program that takes place. So we came up with a method to calculate what buffer you actually need to get a certain probability of overtime, which heavily increases then the utilization. We looked at the question, do you need an operating room or not? An emergency operating room, because the hospital in Rotterdam was the only one in the country that didn't have an emergency operating room. So is that a clever thing to do? And we demonstrated that the break-off point is 8 operating rooms or more. This is where it's better to have this system where you don't have emergency operating rooms, because there are many break-in moments in the schedule where you can fit in that emergency patient. Because if you have emergency operating rooms, it's capacity waiting for a patient that may arrive or may not. Right? So the break-off point is around 8. We also looked at scheduling, sequencing the surgeries in such a way that the break-in moments are spread as much as possible over the day. And this is a new type of scheduling problem, and we demonstrated we could reduce the waiting time of emergency patients by 30% doing this. So, and now our research is focused on optimizing the entire care pathway. So, integrated planning of the departments, trying to jointly optimize quality of care, quality of labor, and productivity at these levels of control. And this is very, very complex. The outpatient clinic interacts with diagnostics, the operating room, the ED. You have clinics, and there's a lot of variability in the process, a lot of waiting, a lot of running and standing still. And local optimization leads to bullwhip effects, leads to staff complaining, leads to patients complaining, so not what they want. So here's a simple example of one of the projects we did, and this is about relating the block schedule of the operating rooms with the inflow into the wards. So what you see here is a block schedule Monday to Friday and 8 operating rooms, and this particular hospital wanted to have an extra operating room. The 8th operating room was actually the new operating room, and they wanted to know how many more beds do we need when we open another operating room. So we translated it in, so how can we calculate the number of beds based on a master schedule? And from historical data, you can calculate a discrete distribution telling you the probability that there's 1 surgery or 2 surgeries or 3 surgeries. You can simply get that from historical data. And also, you can get from historical data the length of stay of the patients in the wards, the probability that it's 1 day or 2 days or 3 days, etc. Right? And then you can convolute these discrete distributions to calculate then the expected inflow or the inflow in the wards. And this was a 2-week master schedule, and the dark blue line is the line that we got with the 7 operating rooms. And you see it's very busy on Thursday and Friday and slow in the beginning of the week. So what we did is we moved around these blocks, these surgery blocks, yeah, and we added the 8th operating room, and then we got this line. The, what is it, pink line? So you see actually the maximum bed usage is lower with the added 8th operating room, but with an optimized block schedule. In most hospitals, using this model and iteratively optimizing these blocks, we can reduce the ward levels by 15 to 20%. It's a huge impact on hospitals and a fairly straightforward calculation. Lots of things you can do about integral capacity planning, tactical planning of the outpatient clinic in relation with the operating rooms. We're focusing on that. Appointment scheduling mixed with walk-ins is a topic of research that we're focusing on right now. Rapid diagnostics for cancer is a big topic. Case mix planning, since hospitals are redesigning the case mix, and then what kind of impact does that have on surgery? Bed planning, pooling and unpooling wards, that's a big topic of research. Rostering and flexible staffing of wards. Rehabilitation planning, long trajectories where patients stay in a care pathway for 1, 2, or 3 years with many appointments, multidisciplinary care, very complex scheduling. So there's lots and lots and lots of opportunities for doing wonderful operation research. Now I have a couple of more slides on variability management, but I could stop here. Stick to the time. Cool.
Too much variability, but I hope you can discuss it furthermore. So, thank you so much. Because we stopped it now, there's also a few opportunities for questions. Yeah, so please.
Yes.
Thank you very much for the interesting presentation and the work that you're doing in the hospitals. What I want to find out is how much of your research involves the formal ethics review processes. How difficult is it to maneuver through those processes? Because I know that in some cases it's a mission to...
Oh yeah. So this is actually currently a big topic of debate in the Netherlands. There was a guy in court actually who took a USB stick with patient information out of the hospital. And so hospitals are now very keen on guarding their patient-related information. The information we need is always anonymized. We're not interested in patient names. We're interested in patient types and the characteristics. So we typically have no problems with ethics committees in hospitals. Our university is pretty late with installing an ethics committee. We're actually doing it at this moment. We recently have a new policy, just the week before I came here actually. I got the new policy letter that we have to comply with. And so all the research involving people, so that's just about all the research, now has to go through the ethics committee, and it has a lead time of 2 weeks. So that's not bad, I think, but I've heard in some countries like Australia it can take up to a year to go through ethics. Yeah, and here too. Okay. Yeah, that's pretty poor. Yes?
The cartoon you've included on the slide there, is that completely tongue-in-cheek, or is that something you guys have also looked at?
No, so a change of culture is the hardest change in any organization. So often we require a change in culture when we implement our ideas. So this is what we struggle with, and are sometimes successful, but sometimes not. So this is a cartoon that appealed to me because of, it's exactly about this. Yeah.
On that point, I've spent some time in Canadian hospitals where they've gone through huge lean exercises, but the problem is the sustainability of the intervention, purely because it's so difficult to change it.
Absolutely, and this is poorly researched. So one of the ideas we have is to analyze the maturity of the implementation. And ultimately what you would like to see is that after many years, the change is still implemented in place. And I haven't encountered any of this kind of research where this is actually done. So the level of maturity of impact of valorization is still quite low. Yeah, but it's a good point.